man presents to the office with complaint of pain in his left great toe. Pain started 2 days ago and has been progressively getting worse to the point that it is difficult to walk even a few steps. He adds that his left big toe is swollen and hot to the touch. He has never had similar symptoms in the past. He normally drinks 2 to 3 cans of beer every night, but recently binge drank 3 nights ago. Physical examination is notable for an overweight gentleman, BMI of 35, in moderate pain with an erythematous, swollen, and exquisitely tender left great toe. Lab results reveal uric acid of level 9. A complete blood count shows hemoglobin 12, hematocrit 45%, MCV 90, platelets 160, 100, leukocytes 8,000, neutrophils, well, okay, those are the percentages. RBCs 5.6 million. So the synovial fluid analysis shows cell count of 15,000 and crystals negatively birefringent crystals present, culture pending, gram stain, no organism is seen. Which of the following is the mechanism of action of the drug that will most likely be used in the long-term management of this patient? Options: inhibits renal clearance of uric acid, inhibits xanthine oxidase, activates AMP deaminase, AMP stands for adenosine monophosphate, increases renal renal clearance, excretion of uric acid, and activates IMP dehydrogenase. Last question. So this is a patient with left great toe pain, erythema, swelling, overweight man who just binge drank beers, I think 3 nights ago. And we did a synovial fluid kind of analysis that showed negatively birefringent crystals called, and gout. So the condition itself is called gout. The crystals that are getting deposited are what we call the monosodium urate crystals, right? When they get deposited in the joints, it usually causes inflammation. And inflammation, we know it has four main we can say signs, right? Redness, erythema, which is erythema, right? Swelling, pain, and warmth. All those symptoms, when you do the physical exam on these patients of the joints, you're going to see inflammation basically. Now, what is causing gout, right? As the name, as we talked about the urate crystals being deposited, we know that it's kind of uric acid getting deposited in a crystal form, and this patient's uric acid was 9, which is elevated, right? So it's basically the derangement and abnormal levels of uric acid. Now, uric acid is a byproduct of purine degradation pathway, right? So our purines, when they get degraded, they become uric acid, right? So either there is overproduction or there is under excretion of uric acid. Increased red meat consumption, alcohol. I think alcohol is more of under excretion and not overproduction. Myeloproliferative neoplasms, yes, so malignancies, right? Malignancies can cause overproduction of uric acid. Leukemias, again, overproduction, right, of cells. When you have cells getting broken down, you're basically breaking down DNAs. DNAs has purines, right? Purines, when they break down, they make uric acid. So think about more cells, more purines, more uric acid. Think about more cells when they break down, they're going to make more uric acid. So yes, tumor lysis syndrome, when you give chemotherapy to someone, they are prone to gout, okay? Now, under excretion, can somebody name conditions or situations where you can have under excretion of uric acid? Tumor lysis syndrome is going to be overproduction of uric acid. We are talking about under excretion. Dehydration, right? Renal failure, yes, chronic kidney disease. Certain medications can also block uric acid excretions, right? So these all are the conditions and situations where you can have under excretion, right? Both of these things, either overproduction or under excretion, can cause accumulation of uric acid. Okay, so loop diuretics, they do cause under excretion of uric acid, and it causes hyperuricemia, and it can also precipitate gout. We actually had to switch this patient from furosemides to another diuretic, start him on acute management for gout, and then a long-term management. So allopurinol, febuxostat, probenecid, these all are chronic medications. Okay. Now let's see how all of these work, right? So the answer we know already, it inhibits xanthine oxidase. The answer is allopurinol, right? Why not others? Let's see. So inhibiting renal clearance of uric acid. If you inhibit renal clearance of uric acid, you're going to increase the level of uric acid and you're going to worsen the patient's situation. So that's why A is not the answer. Make sense? What is the other option? Activates AMP deaminase. Now, AMP deaminase, it causes conversion of AMP to IMP, and then IMP gets broken down into the purine degradation pathway. So you're basically activating the purine degradation pathway. You're basically going to increase the uric acid production. Again, you are going to worsen the patient situation. That is why C is not the answer. Increases renal clearance of uric acid. Yes, it's probenecid that increases the renal clearance of uric acid. I did mention it is a long-term management, but allopurinol is the treatment of choice. So if you have to choose between allopurinol and probenecid, choose allopurinol. Okay, probenecid is not that much used. It's just used for like maybe for conservative. Like if you want to add something along with allopurinol, you can add that medication. Okay. Now, last option is activates IMP dehydrogenase. So IMP dehydrogenase converts IMP to GMP. Okay, and that enzyme is in purine synthesis. It's not even part of degradation. So it has nothing to do with this patient's condition and even the question itself. Okay, so that's why E is not the answer.
Thanks for watching. Please give a thumbs up and subscribe for more.